everyone?
Yes, yes.
Okay. So good evening to everyone in India and good morning to everyone here in the US. I'd like to thank Dr. Badada and the organizers for the opportunity and invitation to speak in the symposium today. I'll be talking on the bone status in endogenous hypercortisolism. So I have nothing to disclose. And the bulk of my talk today will be focused on the effects of overt Cushing syndrome and mild autonomous cortisol secretion on skeletal health. These two areas will be covered by looking at the prevalence of fractures, imaging modalities to assess skeletal health in these populations, and the utility of bone turnover markers. I will then briefly cover on the management of bone health in endogenous hypercortisolism and discuss should we be screening for endogenous hypercortisolism in patients who present with low bone mass or osteoporosis or fragility fractures. So endogenous hypercortisolism can be divided into ACTH dependent, which is the majority in up to 85% of patients, and ACTH independent cases, which is about 15% of patients. The bulk of ACTH-dependent cases are due to pituitary adenomas, and about 10 to 15% of these cases are due to ectopic Cushing syndrome, typically arising from a neuroendocrine tumor, pictured here by a bronchial lesion. In the ACTH-independent cases, the most common cause is a unilateral adrenal adenoma, followed by rarer causes such as adrenal cortical carcinoma or bilateral nodular disease of the adrenal glands. In ACTH-dependent cases, they almost always present with overt Cushing syndrome, but in adrenal hypercortisolism, patients can present with a variable severity of cortisol excess, either from overt Cushing syndrome with external manifestations of cortisol excess, or mild autonomous cortisol secretion, also known as MACS, where they do not have the classic external features of cortisol excess, but the subtle state of cortisol excess puts them at risk of developing comorbidities associated with cortisol excess. And I'll be talking more about this as we go on. So when we look at the characteristics of patients with overt Cushing syndrome, the prevalence of overt Cushing syndrome is rare, and the reported incidence is about 2 to 3 per million per year. But, and when we look at the onset, it's usually rapid with ectopic Cushing syndrome, but otherwise insidious in pituitary or adrenal Cushings. The age distribution is pretty similar in all three groups. And in the ACTH-dependent cases, they can present with some features of androgen excess. Serum cortisol is high in all three groups, and the probability of cure with definitive treatment is high in pituitary and adrenal Cushings, but can be variable in ectopic Cushings depending on the prognosis of the underlying malignancy or tumor. Now, moving on to what is the effects of cortisol excess in overt Cushing syndrome on skeletal health. So this was recognized long before, and this was actually an excerpt from a case series that was published by Harvey Cushing himself back in 1932. And you can see this was on an autopsy of a 25-year-old female patient. He had reported marked osteoporosis of the skeletal was found, it being easily possible to cut the vertebral bodies with a knife, the spongy part of the bone having largely disappeared. So when we look at prevalence of fractures in patients with overt Cushing syndrome, there have been several studies that have been done looking at this, and what I've kind of summarized them all together in this slide. And what they've commonly found is that fracture occurs in the thoracic and lumbar vertebra most commonly, followed by hip, ribs, and pelvis. And there is a very wide range of prevalence that has been reported, anywhere between 21 to 76%. And the smaller percentages are based on studies that actually looked at symptomatic fractures that was reported by patient, or they actually presented with symptoms. And the larger percentage were based on asymptomatic fractures that was identified on patients' imaging. And most studies used the Genant scale to classify them as fractures. But what I want to point out is there is a lot of heterogeneity among these studies, because each studies have actually applied different diagnostic criteria to classify their patients with Cushing's. And as it's a very rare disease, the patient population itself is very small in each of these studies. But what was noted is that overall, there is an increased risk of fractures in this group of patients. but they did not notice any difference between the prevalence between if they are either ACTH dependent or ACTH independent case. This was a study from Denmark where they looked at patients with overt Cushing's syndrome, and the prevalence of fractures in this study was actually 40%. But what they had noticed is that patients with Cushing's had a 5-fold increase of fracture, and the highest risk is immediately before they were diagnosed, and they said about 2 years prior to diagnosis. And what if they actually receive definitive therapy, their risk of fractures actually reduces and normalizes following treatment. So how do we identify patients at risk for fractures? The most widely available tool and what is considered gold standard for evaluating bone mass and predicting fracture risk is the DEXA bone density scan. This table summarizes the largest studies of patients with overt Cushing's syndrome investigated by DEXA. A few things to highlight is that as the condition is rare, even the largest study has no more than 80 patients. And the majority of patients who presented were young, so Z-scores were used to assess their bone mass. And typically, as you all know, a Z-score less than -2 is considered low bone mass for age. But despite an increased reported prevalence of fractures in these studies, as you can see, their bone density values are usually within normal or osteopenic range. And this highlights that DEXA bone mineral density may not be the most sensitive modality to identify patients with Cushing's who are at risk of fractures. And we are likely missing the effects on bone mineral density on bone quality itself. So alternative imaging fractures, and can we do better at predicting risk of fractures? So I'm sure everyone is well versed with trabecular bone score, and it's an imaging modality used to actually assess bone microarchitecture. It is widely available in most tertiary care centers here in the US. And the good thing is patients do not need any additional scan time or radiation exposure for TBS. It just uses a software that's already installed on a DEXA computer to provide an index of bone microarchitecture. Importantly, it has been shown to better predict fracture risk and aerial bone density scans in patients with other metabolic bone diseases. So just to point out, a high TVS value means that the microarchitecture is dense, it's well connected, bone microarchitecture is dense, well connected spaces between the trabeculae, and conversely, a low value is classified as degraded microarchitecture, and the bone is incomplete with architecture is incomplete with disconnected spaces between the trabeculae. At present, TBS is only used to predict fracture risk at the spine. So there were very few studies which actually looked at evaluating trabecular bone score in patients with endogenous Cushing's syndrome. But this is one of the largest studies where they had 182 patients. The mean age was, once again, they were younger patients. And the prevalence of fracture reported was up to 44% of all fractures, and vertebral fractures was 38%. But if you look at the bone density values, they once again fall within either normal or osteopenic range, but their mean spine trabecular bone score falls under the category of degraded microarchitecture. This is a study from France, and they followed up a limited group of 14 patients after treatment for Cushing's syndrome and compared their bone mineral density and trabecular bone score changes over a 2-year period. And if you can see at baseline, their bone mineral density score at the start was actually within acceptable range. And over the follow-up period, there was a very slow improvement in their bone density values. In the trabecular bone score, about half the patient at baseline was already classified with degraded microarchitecture, and you observed a more rapid and intense improvement in trabecular bone score than bone mineral density scans values. Although it's a limited number of patients, it just highlights that there's the most sensitive, trabecular bone score is more sensitive to detecting changes in bone following withdrawal from cortisol excess. So how does cortisol excess affect the bone microarchitecture? Most of our knowledge on the pathogenesis comes from studies of animal models or patients treated with exogenous glucocorticoids. And earlier on, for much long ago, it was thought that the pathogenesis was mainly based on the extraskeletal effects of glucocorticoids, such as hypogonadotrophic hypogonadism, the changes within calcium metabolism, and a decrease in adrenal androgens or growth factors. There are many studies looking at all these factors in patients with overt Cushing syndrome and their effects on bone, but their findings have been pretty inconsistent. And over time, our understanding on glucocorticoid-induced osteoporosis has revolutionized. And over the most recent decades, I think we have improved our understanding by the direct effects of glucocorticoids onto cells that regulate bone metabolism, such as the osteocytes, osteoblasts, osteoclasts, and in turn, the effect they have on bone formation and bone resorption. So osteoblasts are cells that have a vital role in bone formation. They secrete the matrix proteins that are building blocks for bone. And osteoblasts are formed from differentiated mesenchymal stem cells. And what we know from studies of exogenous glucocorticoids, in a state of glucocorticoid excess, there's increased differentiation of these mesenchymal progenitor cells to form adipose tissue within the marrow. Glucocorticoids can also increase expression of rank ligand and suppress Wnt signaling, which in turn causes increased osteoclast differentiation. And very, very high doses of exogenous glucocorticoids can be directly toxic to osteoblasts, causing them to undergo apoptosis. So the net effect is predominantly reduced bone formation and some increase in bone resorption. So how do we
Dr. Shobana, you are mute. Dr. Shobana, you are mute.
Can you hear me now?
Yes, please.
Sorry, I'll just get back to my slide. Where did you stop hearing me?
Yeah, the same slide. Yeah, same slide.
In osteoblasts? Okay, just give me a second. Just give me a second. Okay, so how can I'll just move forward to give me okay, so as I said, we can measure osteoblast activity with osteocalcin and P1NP. And in a state of glucocorticoid excess, we would expect both these values to be low. Now, moving on to osteoclasts, they are the key cells in bone resorption. And I said earlier, with glucocorticoid excess, we know there's increased differentiation of osteoclasts, and glucocorticoid in excess also has an effect on calcium metabolism, sex steroids, and growth factors, which in turn can increase osteoclast differentiation. So how do we measure osteoclast activity? We can measure CTX, and in older studies, they measured deoxypyridinoline, and these are all cleave products of type 1 collagen when bone resorption occurs, and it's a marker of osteoclast activity. So in a state of glucocorticoid excess, we would expect these values to be higher. Now, finally, osteocytes, they are terminally differentiated osteoblasts, and they're kind of like neurons within the bone microenvironment. They have these long cytoplasmic extensions, which are used for exchange of nutrients and waste products through gap junctions. They secrete substances which, through their dendrites, can either recruit or inhibit osteoclast or osteoblast activity and also influence bone remodeling. The activity of the osteocyte and the substance it secretes or who it recruits or inhibits is very much influenced by the variety of factors around them in their environment, such as what is the mechanical stress on the bone, or what is the circulating hormones, or what is hormone levels, and how much of the amount of calcium or phosphorus is in the bloodstream. So sclerostin is a biomarker that was very recently discovered and it's still finding its way in clinical applicability. It's mainly used in the research setting. It is solely secreted by osteocytes in the body. And what we know from animal models and experimental studies is that in a state of glucocorticoid excess, there is increased expression of SOST gene within the osteocytes. And in turn, there's an increase in sclerostin levels, which will stimulate osteoclast activity. So we would expect that in a state of glucocorticoid excess, sclerostin levels will be high. So can we use bone turnover markers to assess skeletal health in patients with overt Cushing syndrome? So this table summarizes most of the studies that was done to look at bone turnover markers in patients with overt Cushing syndrome. A few things to highlight is that it's a rare disease, so the number of patients in these studies are very small. And when we look at markers of bone formation, you can see that the marker that is consistently decreased across all studies is osteocalcin. But the other markers of bone formation, such as bone alkaline phosphatase or P1NP, had very inconsistent results. And when you look at markers of bone resorption, they're all over the place. Some of them are increased, decreased, or normal. So we can conclude by saying that osteocalcin is the best serum biomarker to evaluate reduced bone formation and skeletal health in patients with overt Cushing syndrome, and bone resorption markers do not demonstrate consistent results. So how do we manage skeletal health in patients with overt Cushing syndrome? I think no matter what the comorbidity associated with Cushing syndrome, the first line of treatment is always to address the underlying cause of Cushing syndrome. And hope to achieve a definitive treatment for the overt cortisol excess. And as I pointed out earlier, the risk of fractures actually normalizes following definitive treatment. But in cases where there's persistence or recurrence, we always opt for a try for definitive treatment again, or other treatment modalities to treat the cortisol excess. But at times, patients may need an addition of a bone protective therapy. There is very much a lack of evidence or studies looking at bone protective drug therapy for patients with endogenous cortisol excess. And at present, the guidelines for management of patients with endogenous overt Cushing syndrome from bone standpoint is very much reliant on what has been the guidelines for patients on exogenous glucocorticoids by the American College of Rheumatology or International Osteoporosis Foundation. And I will be going through that later on in my talk. So far, we have discussed about patients with overt Cushing syndrome, and I'm just going to shift gear and talk about the patients with mild autonomous cortisol secretion, or previously known as subclinical Cushing's. These are patients with either unilateral or bilateral adrenal lesions without external classic features on clinical examinations, but have mild cortisol excess on biochemical workup. So I'll give you an example of a clinical case of a patient that I recently saw. So we have a 64-year-old male with a BMI of 31. He's a type 2 diabetic with a relatively well-controlled A1C of 7% on three oral therapy medication. He's hyperlipidemia on a statin and hypertension controlled on 3 medications. He had a CT scan done for another reason, and incidentally, a right adrenal adenoma was noted, and it was benign characteristic. The pre-contrast CT Hounsfield units was -7. His cortisol following 1 milligram dexamethasone suppression test on 2 separate occasions was 3.1 and 2.4. And as per the guidelines, more than 1.8 is considered cortisol excess. And his baseline ACTH was low at 8, and his 24-hour urine-free cortisol was within normal range. He had a DEXA bone density scan, which showed osteopenic range within the lumbar spine and the hip. His physical examination did not reveal any external manifestations of Cushing syndrome. So what we have here is a patient with very subtle state of cortisol excess. He has a, which is noted on his 1 milligram dexamethasone suppression test, a low ACTH, no physical findings of Cushing's, but he has increased risk for cardiovascular disease, and his bone density is in the osteopenic range. So this is a patient with mild autonomous cortisol secretion. And I just want you to think about the next step in management of this patient. So should we intervene? No, should we say no intervention at present? We'll follow him up yearly and see if he's and with clinical exam and biochemical evaluations to see if he might progress to overt Cushing's, or we'll continue medical management of comorbidities with diabetes, hypertension, osteopenia, obesity, or should we send him for an adrenalectomy of his right adrenal gland? Or should we discuss with the patient about the effects of mild autonomous cortisol secretion and allow the patient to make an informed decision about what he would like for his treatment? So mild autonomous cortisol secretion is a condition defined as patients with an adrenal mass and biochemical evidence of hypercortisolemia, but without the classic clinical manifestations of overt Cushing's syndrome. There were many different terms used to describe this condition before, such as subclinical Cushing syndrome, subclinical hypercortisolemia, preclinical Cushing's, but we have to ask ourselves, when we say subclinical, does that mean that the patients are not at risk of developing clinical complications like cardiovascular disease or fractures? And when we say preclinical Cushing's, do they actually progress to overt Cushing syndrome later on? So what is the prevalence of MACS? Incidentally discovered adrenal tumors are reported in approximately 5% of adults undergoing cross-sectional imaging. In the US, annually, around 80 million patients receive CT scans. So that gives us a number of about 4 million patients who discover incidental adrenal masses annually. Prior to 2016, there was no standardized guidelines on how to actually work up patients with adrenal incidentalomas for cortisol excess. Then in 2016, the European Society of Endocrinology, along with NSAID, came up with the guidelines for evaluation of adrenal incidentalomas, which has been adapted into clinical practice here in the US and other countries. And based on these guidelines, a low-dose dexamethasone suppression test is the recommended test for these patients. And based on these tests, if they have a value, a cortisol following low-dose dexamethasone suppression test of less than 1.8, micrograms per deciliter, we would say it's non-functioning. Between 1.9 to 5 is possibly autonomous cortisol secretion. And if it's more than 5, it's confirmed autonomous cortisol secretion. And based on these guidelines, in reported recent studies, the prevalence of MACS is up to 1 to 2% of the general population. So if I add this adrenal MACS to the table we had seen earlier in overt Cushing syndrome, this condition is far more common compared to overt Cushing syndrome. It affects 1 to 2% of the general population, and studies have shown that it can be present in up to 50% of benign adrenal incidentalomas. The onset is insidious, and it tends to be diagnosed at later stages because patients don't have the classic external manifestations of Cushing syndrome. And there have been studies which say that they can co-secrete aldosteronism, so they may not have pure cortisol excess. And serum cortisol is high, and probability of is increased, not as high as overt Cushing, and the probability of definitive cure is high with an adrenalectomy. So do they progress over time from MACS to overt Cushing syndrome? This was a meta-analysis published in 2019, looking at 23 studies involving 2,700 patients with incidentally discovered adrenal tumors, either non-functioning or with MACS, and was followed up for a period of 50 months. And overall, only 6 patients out of the 2,700 patients, 5 were non-functioning and only 1 was MACS, progressed to overt Cushing syndrome. So it was reported to be 0.2%. So the guidelines actually say that autonomous cortisol secretion is not a condition with a high risk for development of overt Cushing syndrome. However, this image summarizes many of the studies which evaluated if patients with MACS actually have an increased prevalence of metabolic risk factors compared to the general population. So the black bar is patients with MACS, the white is general population, and the gray is non-functioning adrenal tumors. And you can see that all across, they have a higher prevalence of cardiometabolic risk factors such as hypertension, obesity, dyslipidemia, and diabetes. This is one of the largest published study till date on cardiometabolic comorbidities in patients with MACS. And they compared patients who underwent adrenalectomy versus conservatively followed up for management of their comorbidities. And overall, patients who underwent adrenalectomy across has shown that they have improvement in their cardiometabolic risk factors, but those who were conservatively followed up either had progression or new diagnoses of other cardiometabolic risk factors. So we've shown that MACS actually has an increased risk of cardiometabolic risk factors, and how does it actually affect skeletal health? So this table summarizes the prevalence of fractures and the DEXA bone density finding on studies on patients with MACS. Most of these studies come from a group in Italy by Chiodini and his colleagues, and they are cross-sectional in design. And once again, to highlight, majority of these studies have a very small number of patients. And they were all done before the standardized guidelines in 2016. So they used differing criteria to diagnose patients with MACS. But once again, their bone density score findings are anywhere between osteopenic or normal range, but the reported prevalence of asymptomatic vertebral fractures, most studies used the Junand scale, was anywhere between 50 to 80%. And their control group, which is non-functioning adrenal tumors, were much lower at between 21 to 46%. This is a study which looked at a small group of patients where they had patients with MACS who either underwent adrenalectomy or was followed up conservatively. And at the end of the follow-up period, they found that the new incidence of vertebral fractures was much higher compared to the patients who was conservatively followed up. Now, if bone mineral density score, once again, is not as sensitive, how do we fare with trabecular bone score? So this is one of the largest studies done again from the group in Italy, and they looked at 34 patients with MACS compared with 68 non-functioning and 70 controls. And they looked at their bone density scan, trabecular bone score, and prevalence of fractures. And they had 40 of these patients followed up over a longitudinal period of 2 years. And what they found was in their cross-sectional arm, low TBS had the best sensitivity to detect fractures in these patients, and a combination of bone TBS and bone density together had better specificity for detecting fractured and non-fractures in patients. And they also found in the longitudinal arm that TBS was independently associated with predicting fractures risk regardless of other confounders. So how can we use bone turnover markers in patients with MACS? This table again summarizes, similar to the one before, findings of bone turnover markers in this group of patients. And once again, if you see the most commonly reduced bone turnover marker, marker of bone formation is osteocalcin. Not in all studies, but it is the most consistent one. And in bone resorption markers, the findings are all over the place. Some are either increased, decreased, or normal. Now, I'm just going to go back to talk about osteocyte and sclerostin levels, where I had mentioned before that in a state of glucocorticoid excess, there's increased regulation of SOS gene from what we know, and we would expect increased osteoclast activity and sclerostin levels to be higher. So this is a study I published during my time in Mayo, and this was published last year, and this is one of our largest studies which looked at patients with MACS. We had 92 patients with MACS and 99 patients with non-functioning adrenal tumors. And we looked at the evaluation of bone turnover markers. And interestingly, we did not find a significant difference between markers of bone formation, such as osteocalcin and P1NP, or marker of reception of CTX. But what we found was there was a significant difference in sclerostin levels between patients with MACS and non-functioning adrenal tumors. And we had expected sclerostin levels to be much higher because of upregulation of SOS gene known from patients on steroid treatment, but we found that sclerostin levels were actually much lower in patients with MACS. And in a limited group of patients where we compared them pre and post adrenalectomy, we found that the sclerostin levels actually improved after adrenalectomy, and it actually went higher. So, and if you remember, I had said that sclerostin is only produced by osteocytes in the body, and it made us think that following adrenalectomy, there's actually an increase in the number of osteocytes function and number, and that's why the levels improve. And this was also demonstrated by a study from a group in Netherlands, where they had looked at patients with endogenous cortisolism, and controls, and they found that sclerostin levels were much lower in patients with endogenous cortisol excess, and their levels improved after surgery. This study also looked at FGF23 levels, which is also secreted only by osteocytes, but not affected by glucocorticoids. And they noted that the levels actually of FGF23 improved following treatment for cortisol excess. So this strongly supports the hypothesis that the increase in sclerostin levels after treatment for endogenous hypercortisolism actually restores osteocytes' number and function. And what we know from exogenous glucocorticoid treatment on bone, there's two phases. There's a rapid phase where the first few months of treatment, there is uncoupling of bone resorption and bone formation. And what happens initially is an increase of bone resorption, and that's the predominant pathogenic factor. But over a prolonged period, the chronic phase, what then happens is reduced bone formation, and it's actually been shown to have osteocyte apoptosis. So in patients with MACS, although their state of cortisol excess is considered milder compared to overt Cushing's, the chronic exposure to cortisol excess, even at a lower level over a longer period, puts them at risk of osteocyte apoptosis, which is demonstrated by low sclerostin levels. And over time, if it gets its place more in, sclerostin gets a place better in clinical applicability, it probably may be a good biomarker for evaluating skeletal health in patients with MACS. So back to our patient that we had discussed earlier, what I just wanted to point out is that in patients with MACS, they are at risk of increased cardiometabolic risk factors and also affecting their skeletal health. And we kind of have to take this into the picture when we assess them to decide what is the best treatment for them. And the management of patients with MACS is not straightforward. We have to make a clinical assessment looking at their comorbidities and also consider other factors such as their age, their degree of cortisol excess, what is the personal preference for the patient, and tumor size, imaging phenotype. And as putting all this together, if you think the patient would benefit from an adrenalectomy, then yes, proceed with an adrenalectomy. But if not, we should have a plan to follow them up yearly, on a yearly basis to reassess their comorbidities. Their risk of changing progressing to overt Cushing's is very low, but it's reassessing their comorbidities and maybe giving intensifying medical therapy that is appropriate to treat them, their comorbidities. But the good thing is there are potential biomarkers in the horizon that are being understudied to see if we can make we will be better at evaluating patients with MACS for their severity of their condition and help patient selection that might best benefit from adrenalectomy. So if a patient chooses not to go for surgery, how should we medically manage their bone disease? And there's not much evidence or comparative studies looking at what is the best medical treatment for patients with MACS. There was one European study which looked at a bisphosphonate clodronate, which showed there is some bone mineral density improvement, but there's no data on fracture risk reduction. So at present, like I said before, we refer to the guidelines of exogenous glucocorticoid-induced osteoporosis. And if we have a patient who's considered low risk, where there's absence of fractures and bone mineral density reduction, then you would recommend them to intensify calcium and vitamin D supplementation. But if they are high risk, such as postmenopausal women and men greater than 50 with fragility fractures or cracks, calculated cracks with a higher percentage, then we would go ahead with treatment with the bone protective therapy. And when we look at the guidelines as per the algorithm, the first line of treatment on exogenous glucocorticoids is recommended an oral bisphosphonate. But like I said, we don't know what the anti-fracture effect is for oral bisphosphonates. And in Cushing's and MACS, the main pathogenic mechanism I've pointed out is reduced bone formation and probably a slight increase in bone resorption when you have a state of chronic cortisol excess. So possibly an anabolic therapy might be a better first option for them. But like I said, we do not have much data or comparative studies on these populations. So finally, should we screen for MACS in patients with osteoporosis? There are 4 studies looking at prevalence of MACS in patients who actually presented with low bone mass, fragility fractures, or osteoporosis. But I'd like to point out that these studies used different screening and cutoffs for the categorization of patients with MACS. And overall, the prevalence that they found was low. It's between 1 to 4%. And at present, we don't have enough evidence to recommend that this can be generalized and we should be screening everyone for this condition. And it still stands that we should only screen for severe cases. But the guidelines, which is considered severe cases, are patients with low Z-scores or more rapid decline of bone density or failure to, for bone density to respond to appropriate therapy, or presence of fragility fractures in eugonadal or premenopausal females. But like as I've demonstrated before, bone density scans on its own may not be a sensitive tool to predict fracture risk in these populations, and we should consider use of TBS to increase the sensitivity and specificity in these patients. So in summary, overt Cushing syndrome is a rare condition, and adrenal MACS is much more common. In both these groups, there has been data to show that there's an increased risk of symptomatic and asymptomatic fractures. DEXA bone mineral density scan is a widely available tool, but may not be reliable to predict fracture risk. And trabecular bone score is a better tool to predict fracture risk in these populations. And there is evidence to show improvement, slow improvement in the bone density, but a much more rapid improvement in TBS and improvement in incidence of fractures following remission of hypercortisolism. If you're going to use bone turnover markers in patients with overt Cushing's, osteocalcin has shown to be a good marker to identify reduced bone formation. Adrenal MACS patients, osteocalcin is somewhat shown reduced bone formation, but there has been emerging evidence that low sclerostin levels may be a good predictor, but it's not available in clinical practice. And when it comes to treatment with overt Cushing's, we always target to remove the source of endogenous hypercortisolism. But in adrenal MACS, it's either adrenalectomy or aggressive management of their comorbidities. And when it comes to management in their skeletal health, like I pointed out, probably anabolic therapy may be a better option for them. And we'll have a talk later by Dr. Kosman on anabolic therapy. So it'll be good to see if she has something to add to this. But the good thing in adrenal MACS, patient selection for adrenalectomy can be challenging, but there are emerging biomarkers to assess disease severity and help select patients who best benefit from adrenalectomy. So I hope I've covered the objectives that we set out in the beginning of the talk today. And with that, I thank you again for the invitation today. And I think I'm not alone when I say we're all very devastated by what's happening in India right now. And I sincerely hope things improve soon and we'll be able to see each other in person, and you're all in our thought and prayers. And I'm happy to take any questions. Thank you.
So, Shobana, this is Nalini Shah. Could you just stop screen share?
Yeah, I'm going to do that one.
Lovely.
Yeah, hi there.
Hi, Shobana. It was wonderful to listen to you, and thank you for sharing your concepts, and thank you for sharing your work, and in particular, congratulations on your JCNM publication 2020 related to MACS and bone health status. So, I mean, I think Cushing is something which is very centric to many of our institutions across India, and PGI, of course, and also our institute. We have a very huge number of patients with Cushing syndrome, something maybe close to 600 or so. And I think our spectrum tends to be extraordinarily different compared to what gets featured and discussed in the literature across, and especially from the Western countries. So on one hand, when we talk about acetate-dependent Cushing, bone, of course, is one of the major manifestations, but sort of the focus of attention is on many other comorbidities with which these patients come to us, right? And I think these patients come to us in such dire medical conditions that they are bedridden, and even turning in bed leads to fractures for them. So they can be really challenging. Versus that, when we talk about MACS per se, Indian data on MACS is limited. Because I think the use of CT scan across the board in terms of being the common modality is something which comes a little lower on the card. It goes more on a sonography and then CT scan maybe. So MACS per se as a number, we would have very limited number compared to what the Western countries would have. So I think MACS related judgment and decision making vis-a-vis metabolic comorbidities, and now as your added dimension of bone related comorbidities is well taken, especially the dimension of bone that you pictured for us, and the role of osteocytes with sclerostin being the marker is something which is truly well taken, and thank you for that. So I think it's such a wide range of cortisol, age, menopausal status, gonadal functions, and multiple variables that we are talking about. So fitting bone alone as a health in these patients across so many variables becomes truly challenging. But I must say that you've done a great job for us. So thank you very, very much.
Thank you very much for the kind comments. And like I said, when it comes to overt Cushing syndrome, our focus is always treating the Cushing syndrome. And as you pointed out, there's so many comorbidities that we need to address. But I take your point that in US, CT scans are used very easily and readily available. And we are diagnosing more and more of these adrenal incidentalomas. And this is a bulk of a lot of patients who are referred to endocrinology here. And we are seeing more and more these numbers of subtle cortisol excess MACS being diagnosed. So it's more towards working for this group of populations in the Western population where if they have this subtle state of cortisol excess, not everyone is going for surgery. And how can we help manage their other comorbidities? What is the best optimal treatment for them if they do not go for surgery? But thank you again for your comments.
Sure. Yeah. So Rama, would you like to take questions? Or, yeah, please.
Before that, I would just like to ask her that in a severe Cushing who is coming with clinical fractures, as ma'am has said, so how do you decide? We just wait for the Cushing to be treated, or you do treat with something else, or it depends on the menopausal status, age of the patient, that you decide therapy in a patient who has come with clinical fractures and maybe BMD is less than 3 or 3 minus 3.5. Then what do you treat? You wait for the curative surgery, or both the things simultaneously?
So I think, there's no straight answer and there's no standard guidelines for these patients, what we do. But I think in clinical practice that if someone presents with severe Cushing's, we would be rushing to treat their cause of Cushing's itself. But if we start off by looking at their bone density score is very much lower and there is a delay in diagnosing and they are very much at risk of fractures, anabolic therapy is probably what I think is the best thing to start off to treat from their bone perspective. However, like I said, anabolic therapy, it's a maximum of 2 years. And the data has shown that right after treatment for Cushing's, what they've seen in a small group of patients is their risk actually reduces. So I think we have to make a clinical judgment on how severe is the bone disease. What sounds like a lot of them who present are very debilitated. And in your experience, it would be interesting for you. I would like to know, like when you treat patients who are presented with such debilitated bone status after treatment, what have you seen in their improvement of bone disease parameters?
Definitely in our setup, there is improvement in BMD after treating Cushing. So as your thought, we also used to treat if it's severe osteoporosis. But there was a recent paper by Dr. Martin Rinke last year in JBMR who showed that there is something like bone anabolic window, although he did not choose the word bone anabolic window, but there is something like bone anabolic window which happens after treatment of Cushing. So there is improvement in bone turnover markers by so that's something like giving anabolic therapy. So after that study, we actually have stopped using any therapy, and we just wait for, and the retrospective data whatsoever we have, all the patients who actually have curative surgery, they do improve.
Yeah, so the studies have shown that right after treatment for remission of hypercortisolism, the aerial BMD in the spine actually improves significantly. But when they study other skeletal sites, there's actually quite a decrease in the peripheral sites like the radial bone density and everything. And they think there's very good, quick redistribution of bone mineral content to the aerial bone. So typically, it's like primary hyperparathyroidism. Once you treat them, you give it time for bone remodeling again to occur, if you're allowed to. And then if it's still not improving after a certain period, anabolic therapy is probably the best option, I would think.
Sanjay,
Sorry, you're muted. Yeah.
I think Sanjay put a message saying we are running late and wanted to wrap up the questions.
Sure.
Did you want to do that now or should we continue? Sanjay, can you hear us?
Sorry, ma'am.
No, I saw your message that we are running late and we should wrap up.
Yes, ma'am. Yeah.
So, Nalini, do you want to do the honors of wrapping up?
Usha, always your